Hello everyone. Today we talk about acute coronary syndrome. How do we evaluate and how do we approach that? So first thing, we talk about history. History, you want to know the LICORA, location, quality, and onset, radiation, aggravating, elevating factor, associated symptoms, and other things like nausea, vomiting, shortness of breath, sweating, syncope, and you want to know, is it aggravated by exertion? Is it relieved with rest? Is it like elephant sitting on the chest? Like, what is the criteria of the pain? And then you want to know, is there any history of coronary artery disease, CHF, recent GI bleed? Is there any CABG in the past? Is the patient had any stenting in the past? Social history, like smoking, alcohol, drug abuse, we call it SAD questions, what medication they're using. This is the history part. And then we go to the exam part. When we examine, usually you check for JVD, you do cardiac, respiratory exam, abdominal exam, pulses. It's important to check. You're gonna like hepatomegaly, xanthoma, these kind of that you want to do, cardiac or respiratory. Okay. Differential diagnosis for this patient to have possible acute coronary syndrome. The big things could be anstomy or STEMI based on ST. If there's ST elevation or not ST elevation. This is one thing. Other things that you want to make sure you're not confusing them with the acute coronary syndrome are aortic dissection, pericarditis, aortic stenosis, PE, cardiomyopathy, pleuritis, pneumothorax, GERD, diffuse esophageal spasm, anxiety. So these are the differentials that you want to include. And then for lab work, the way we handle it, labs, we usually do CBC, CMP, troponin, BNP, D-dimer, CRP, lipid panel, PT, INR, EKG, chest X-ray, echo. So these kind of the common labs that we want to order for this patient. Now the treatment options, I'll briefly talk about it. For treatment wise, usually you administer analgesia, including morphine, nitroglycerin, and something to reduce myocardial oxygen demand, which including beta blockers, nitroglycerin, morphine, or benzo. And you want to improve the coronary blood flow with cath lab, CABG, or thrombolytics. And you want to prevent intracoronary thrombus using aspirin, Plavix, enoxaparin, or atorvastatin. Period. There is a mnemonic called monobash, which stand for morphine, oxygen, nitrate, aspirin, beta blocker, ACE, statin, and heparin. And the order you want to give these, you start with oxygen, aspirin, nitro, and morphine. Okay. A few things to consider, like for unstable angina, we usually give oxygen, IV excess, aspirin 325 milligram, and then 81 milligram. And then we give nitroglycerin 0.4 milligram 3 times in 5 minutes interval, unless the patient have signs of right heart failure. or if there is contraindication, like if you are recently taken Viagra or alpha-2 blocker like Flomax. And then you give morphine, which is 2 to 4 milligram every 5 minutes if unresponsive, to 3 doses of nitrate. Then you do the morphine, and then you do Lovenox, therapeutic dose 1 milligram per kilogram, or heparin 60 units per kilogram, IV bolus, and urgently, because based on Essence trial showed enoxaparin reduced the composite endpoint of death, MI and recurrent angina, when compared to unfractionated heparin when treating unstable angina. And there is also metoprolol. You can do 5 milligram every 2 minutes for 3 doses, and then 50 milligram every 12 hours. And contraindicated if the heart rate is less than 50, hypotension, or bronchospasm. And you give atorvastatin 40 to 80 milligram. And then you can also give clopidogrel 300 milligram based on the Plateau trial. You can also use ticagrelor even better than clopidogrel, because it significantly reduces rate of CV, MI, and stroke without increasing the overall rate of major bleeding. And that's what the Plateau trial told us, that ticagrelor is better than clopidogrel. This is for anastemi, okay, or unstable angina. If someone have a STEMI, then the best thing is to do is PCI, do door to balloon time ASAP within 90 minutes. And then you can add ACE inhibitor if the blood pressure tolerate after reperfusion therapy, because trials support that it actually decreases mortality. You can do that. And fibrinolysis you can do within 30 minutes of presentation if no PCI available, like TPA in 30 minutes if no PCI available, or the closest PCI is more than 2 hours away. And then usually you do TPA 15 milligram bolus and then 50 milligram IV over 30 minutes. So 15 milligram bolus, then 50 milligram over 30 minutes, and then you transfer to the PCI capable facility. And then CABG, everybody knows if there is a multi-vessel disease, more than 3 vessels, that CABG can be actually indicated. So there is a good idea to do CABG. And then also I forgot to mention about the contraindication for fibrinolytics. Not everyone should receive fibrinolytic. Like if somebody have intracranial hemorrhage, a brain tumor, aneurysm, AV malformation, ischemic stroke within 3 months, active bleeding excluding menses, suspected aortic dissection, we avoid TPA in these cases because the risk will outweigh the benefit in these patients. And after stenting, what you want the patient on? You want the patient on ticagrelor, and you want them on aspirin as well, lifelong aspirin. And then you can do ticagrelor for at least 1 year, regardless if intervention was performed. And you also want atropine ready in case there's a right coronary artery infarct, because right coronary artery supply the AV node, so you could have symptomatic bradycardia, so have atropine in hand. Okay, so these kind of the treatment, kind of summary on the treatment. And the risk factors, now it's easy, everybody knows: diabetes, smoking, hypertension, hyperlipidemia, and this is the modifiable, non-modifiable family history, and males. And the complications, usually the complications include left ventricular failure, it could be cardiogenic shock, arrhythmia, free wall rupture, arrhythmia, free wall rupture, recurrent chest discomfort, pericarditis. So these kind of complications. And then before you discharge the patient, the things that you want to be aware before discharging a patient, as I said, aspirin for life, and then plus you can do ticagrelor for 1 year. Okay, and then you can do high intensity statin therapy. Okay, because based on the studies, miracle trial and prove it trial showed actually that it helps a lot to have statin on board, high intention. You can add ezetimibe to statin if you want. And then echo, you want to order that's for sure. You have them echo schedule either inpatient or outpatient. And then you add ACE inhibitor if LVEF less than 40%. Okay, and then you can add or Entresto as well if there's HFrEF, or spironolactone, or eplerenone if post-MI and left ventricular EF less than 35% with heart failure symptoms or diabetes. And then the other things you consider, possibility of ICD. Patient may need an ICD based on the cardiologist. And then you want to maintain blood pressure below 140/90, and then you encourage for exercise and diabetic control, cardiac rehab, weight loss, good old weight loss, vaccination, screen for depression. They have an increased risk for depression, so I can give them sertraline and manage their depression. So that's basically a brief summary of acute coronary syndrome and how do you manage it. And so history is like basically brief history, location, intensity, quality, and associated symptoms. Exam, full exam, and differential diagnosis. You got to keep those in mind: anastomia, pericarditis, aortic dissection, and then you do CBC, troponin, BNPD dimer, PT-INR, and then you treat them with oxygen, aspirin, nitro. If that didn't improve, then morphine, and then you add metoprolol. This for anastomia. And then for STEMI, you want PCI 90 minutes. If there's no PCI, then you do TPA within 30 minutes, 15 bolus, and then 50 over 30 minutes. And then after stenting, they need to be ticagrelor for 1 year, aspirin for life. And then you do modify risk factors, and diabetes, smoking, hypertension, and the modifiable, and hyperlipidemia. Then unmodifiable, you cannot change your sex or your gender or family history. Complications, you got to be aware of cardiogenic shock, arrhythmia, rupture, and if patient have EF less than 40, you add lisinopril. If less than 35, you can add spironolactone. You can even consider ICD, maintain blood pressure less than 140/90, exercise, diabetic, and weight control. And that's kind of a summary of acute coronary syndrome. Thank you so much for listening.